Cerebellum is located in posterior cranial fossa and it lies behind the brain stem. The brain system consists of midbrain, pons and medulla, and with this brain stem it is connected by three cerebellar peduncles connected to midbrain by superior cerebellar peduncle, with pons by middle cerebellar peduncle, and connected to medulla by inferior cerebellar peduncle. Anatomically, cerebellum is divided into three lobes: anterior lobe, which is also called as paleocerebellum, then posterior lobe, which is called as neocerebellum, and flocculonodular lobe. So the three lobes are there in cerebellum anatomically. The first one is the anterior lobe or paleocerebellum, which is separated from posterior lobe or neocerebellum by primary fissure. So this is the primary fissure, and this posterior lobe has got another fissure that runs across the posterior lobe, and this fissure is called as horizontal fissure. And this horizontal fissure across the posterior lobe divides the cerebellum into two surfaces. One is the superior surface and the another surface is the inferior surface, which rests on the base of the skull. This flocculonodular lobe is also called as Archicerebellum. So to repeat again, the cerebellum is anatomically divided into paleocerebellum, which is anterior lobe, neocerebellum, which is posterior lobe, and archicerebellum, which is flocculonodular lobe. Physiologically or functionally, cerebellum is divided into spinocerebellum, cerebrocerebellum, and vestibulocerebellum. The spinocerebellum comprises of vermis, which is this midline structure, and lateral to the vermis is paravermis, and lateral to paravermis is the cerebrocerebellum. So this is the cerebrocerebellum part, and functionally or physiologically, the flocculonodular lobe is called as vestibulocerebellum, since it has got connections with the vestibular apparatus or vestibular nuclei. The spinocerebellum, it is called spinocerebellum because it receives the tracts from the spinal cord, and these tracts are anterior spinocerebellar tract and posterior spinocerebellar tract that come from the lower part of the trunk and from the lower limbs, and it also receives the tract from the upper limbs, and these tracts are called as cuneo-cerebellar tract and rostral spinocerebellar tract. The area which is lateral to the paravermis is called as cerebellum because it receives the tracts from the cerebral cortex and it sends the tracts to cerebral cortex. So its connections are mainly with the cerebral cortex. That is why it is called as cerebellum. And the third part is physiologically called as vestibulocerebellum, which is flocculonodular lobe, and this is called vestibulocerebellum because it receives and gives the tract to vestibular nuclei. The three divisions, that is vestibulocerebellum, spinocerebellum and cerebrocerebellum. The vestibulocerebellum controls whole body posture, balance and equilibrium, as well as it controls eye movements. The spinocerebellum controls smooth conduction of body movements, and cerebrocerebellum is involved in planning and programming of movements in collaboration with cerebrum. Vestibulocerebellum receives the vestibulocerebellar tract from vestibular nuclei of medulla, which in turn receives the fibers from vestibular apparatus found in internal ear. And here we see that vestibulocerebellum is made of nodule and flocculus. The nodulus area you can see is in alignment with the vermis, and we know that vermis contains the vestigial nucleus. Therefore, vestibulocerebellum is mainly associated with vestigial nucleus. Any tract that is received by vestibulocerebellum or any tract that goes out of vestibulocerebellum is basically coming or going with connection to vestigial nucleus. As I said, the vestibulocerebellum receives the vestibulocerebellar tract from vestibular nuclei, which is situated in the upper part of medulla, and this vestibular nuclei in turn receives the fibers from vestibular apparatus, and this vestibular apparatus is located in the internal ear, and this vestibular apparatus contains semicircular canals. It also contains ventricle and saccule, and fibers that arise from the vestibular apparatus first form the vestibular ganglia, and from this vestibular ganglia the vestibular nerve enters the internal aquatic canal, and then it enters and ends up in the vestibular nuclei. And it is the vestibular apparatus that gives information about the positions of the head and about the movements of the head to the vestibular nuclei and then to the vestibulocerebellum. Now, as I said that vestibular nerve receives its fibers from the vestibular apparatus, which is in the internal ear, and then the vestibular nerve through the internal aquatic canal and reaches the vestibular nuclei in the upper part of the medulla. And from the vestibular nuclei, the fibers go to flocculonodular lobe, or they go to vestibulocerebellum through inferior cerebellar peduncle, and these fibers end up in vestigial nucleus in the vestibulocerebellum. And vestibulocerebellum also sends back fibers to vestibular nuclei. So the ingoing tract is vestibulocerebellar tract and outgoing is cerebellovestibular tract. And from the vestibular nuclei now, the fibers descend downwards as medial vestibulospinal fibers, which go to the cervical cord, and lateral vestibulospinal fibers which go to thoracic, lumbar and sacral cord. And through these fibers the muscles are either contracted or relaxed so that a desired posture is achieved and patient remains in balance. The vestibulocerebellum also receives visual input. So the visual input will come from the field, frontal eye field, and also from superior colliculi and from other visual areas of cerebral cortex. And this will reach to pontine nuclei by cerebropontine tract, and from pontine nucleus it goes to other side of the vestibulocerebellum. So this tract will be called as cerebropontocerebellar tract. Information about motion, equilibrium and spatial orientation, that is orientation of head, neck and body, is provided by vestibular apparatus, which is in internal ear, which includes ventricle, saccule and 3 semicircular canals as we have known. The ventricle and saccule detect gravity, that is information in a vertical orientation, So the atrial and saccule detect gravity and linear movement. The semicircular canals detect rotational movement. If you look at this diagram, you find the semicircular canals, that is vestibular apparatus, which is in the internal ear, sends the message to vestibular nuclei about the position, posture and movements of head and neck, and this message is then sent to vestibulocerebellum, and vestibulocerebellum sends back message. So there is to and fro connection between vestibular nuclei and vestibulocerebellum, and the tracts are vestibulocerebellar tract and cerebellovestibular tract. Then from the vestibular nuclei, the tracts are sent to spinal cord as medial vestibulospinal tract and lateral vestibulospinal tract. Medial vestibulospinal tract ends up in cervical cord, and lateral vestibulospinal spinal tract ends in thoracic and lumbar regions of the cord. And it is through these tracts that position and movement of the neck as well as movements of the eye are adjusted and readjusted according to the need, so that a balance and equilibrium is maintained between the head and the body and in relation to the surroundings and the space. Now you will be asking me how the movements of eye are controlled by the vestibulocerebellum. If you look at this image, again from the vestibular apparatus, vestibular nerve enters into the vestibular nuclei, and vestibular nuclei gives the vestibulospinal tract that goes down into the spinal cord. You will also see here that this vestibular nuclei gives connection to medial longitudinal fasciculus. So this area here is medial longitudinal fasciculus, and this medial longitudinal fasciculus is in the midline of the brain stem. That is it. There is this tract in the midline, and it extends from medulla, pons and midbrain. And this medial longitudinal fasciculus, it is attached by fibers to the tactum, or in other words, it gives the connection to tactum. The tactum is found in the midbrain, and it is the dorsal portion of or posterior portion of the midbrain, which contains the tactum contains superior colliculus and inferior colliculus, and superior colliculus is meant for vision and inferior colliculus is meant for auditory sensations. So it is here that you will find the tactum in the midbrain, and the medial longitudinal fasciculus which receives the connection from vestibular nuclei, and this medial longitudinal fasciculus is connected to the tectum. That means it is connected to the superior colliculus and inferior colliculus that are concerned with auditory sensation and visual sensation, or auditory control and visual control by inferior colliculus and superior colliculus respectively. And this medial longitudinal fasciculus is also connected to third, fourth and sixth cranial nerves. So vestibular nuclei is well connected to the eye through third, fourth, sixth nerve nuclei, which are connected to superior, which have got connections to superior and inferior colliculi, as well as to medial longitudinal fasciculus. And the eye movements are controlled in response to visual as well as auditory stimuli, and also in response to head and neck movements and position of head and neck. And it is through these connections that these eye movements are controlled. I show you again here. This is the vestibular nuclei which has connection with vestibulocerebellum, and this vestibular nuclei is connected to medial longitudinal fasciculus, and medial longitudinal fasciculus is connected to third, fourth and sixth nerve nuclei, and this medial longitudinal fasciculus is also connected to tectum, which contains superior and inferior colliculi, which by these connections control the movements of eye through third, fourth and sixth cranial nerve, and these movements of eye in relation to the position and movements of the head, as well as in response to visual and auditory stimuli, is controlled by these tracts, that is by medial longitudinal fasciculus as well as by vestibular cochlea and vestibulocerebellum. So to repeat it again, the vestibular nuclei is connected to medial longitudinal fasciculus, which is in the midline of the brain stem, extending through medulla pons and midbrain, and this medial longitudinal fasciculus is connected to third nerve, the fourth nerve and the sixth nerve, and this medial longitudinal fasciculus is also connected to superior inferior colliculi of tectum of the midbrain. And once the message is given to tectal area of midbrain, that is tectum of the midbrain, by vestibular nuclei through medial longitudinal fasciculus, the tectum then sends the message through a tract down into the spinal cord, and that goes up to the cervical cord, so that this message is delivered to the muscles of the neck as well as to the muscles of the head, and this can bring increased tone or decreased tone in various muscles of the head and neck, so that the equilibrium and position is adjusted or readjusted according to the eye movements or according to the surrounding and the spatial orientation. In other words, the head and neck movements are mainly controlled by tectospinal tract, which comes from the tectum of the midbrain to cervical spinal cord. Now, what have we learned about vestibulocerebellum? The vestibulocerebellum, we have learned that vestibulocerebellum, in association with the vestibular nuclei, cerebral cortex, and in association with brainstem and spinal cord, control the equilibrium and posture and position of the head and neck and body. So we have learned that vestibulocerebellum controls the equilibrium and posture of head and neck especially, and of the body, as well as it controls and influences eye movements. This it does through extrapyramidal tracts like tectospinal tract and vestibulospinal tract, and also in association with medial longitudinal fasciculus, also in association with third, fourth and sixth nerves, as well as in association with superior and inferior colliculus of tectum of midbrain. And it is through these extrapyramidal tracts that some muscles of head and neck, as well as other parts of body, are inhibited or stimulated, contracted or relaxed, or their tone is increased or decreased, so as to adjust or readjust postures and so as to maintain balance and equilibrium as and when required. And lesions to these connections or areas can result in extreme disturbance of equilibrium and posture of head and neck, as well as disturbance in the movements of eyes, which may result in nystagmus and vertigo, and there won't be awareness of head and neck orientation in relation to space and surroundings, which will be impaired if there is something wrong in these connections or something is wrong in vestibulocerebellum, which will result then in vertigo. The symptoms of vestibulocerebellar syndrome, which can occur due to these connections or due to the vestibulocerebellum, will vary among patients but are typically unique combination of ocular abnormalities including nystagmus, poor or absent smooth pursuit of movements, that is ability of eyes to follow a moving object. There can be strabismus, that is misalignment of eyes, or it may result in saccadic eye movements, that is discontinuous jerky eye movements on following moving objects. There can be diplopia, or there may be vestibular ocular reflex, that is reflex eye adjustment to stabilize gaze during head movement, or it may often be accompanied by nausea and vomiting. So postural orientation and alignment of the trunk with head and neck with respect to gravity and surroundings and space get disturbed. Coordination of movement strategies to stabilize body and equilibrium is impaired. The medial longitudinal fasciculus or tract is one on each side of the brainstem, as we have known, which is situated near the midline of the brainstem and composed of both ascending and descending fibers that arise from number of sources and terminate in different areas. Medial longitudinal fasciculus is the main central connection for the vestibular nuclei, for the cerebellum, and for oculomotor nerve, trochlear nerve and abducens nerve, as well as tectum of midbrain containing superior and inferior colliculus. Medial longitudinal fasciculus connects and integrates all these structures to achieve desired movements as well as desired position of head and neck and eye movements Vestibulocerebellum is connected to these areas through connection to medial longitudinal fasciculus, as we know. Tracts also come from tectum as tectospinal tract and innervate muscles of the neck and upper limbs. So does vestibulospinal tract. The clinical significance of medial longitudinal fasciculus is that a lesion in medial longitudinal fasciculus produces slowed or absent movements of ipsilateral eye, usually associated with involuntary jerky eye movements, that is nystagmus, and it may result in internuclear ophthalmoplegia, that is paralysis of the eye movements. As we now know that ascending tracts arise from vestibular nuclei and terminate in third, fourth and sixth nuclei, which are important for visual tracking. Now coming to another functional division of cerebellum, we got here spinocerebellum, and this spinocerebellum consists of vermis, which is in the midline, and lateral to the vermis, this part is the paravermis, and lateral to paravermis is the area or is the cerebellar hemisphere, which is called as cerebellum. As I already said that this area is connected to cerebral cortex mainly. There are number of nuclei in the spinocerebellum. In the vermis is the vestigial nuclei, and in the paravermis is nucleus interpositus. This nucleus interpositus is made up of two nuclei called as globose nuclei and emboliform nuclei, and lateral, these two together are called as interpositus nuclei, and lateral to this interpositus nuclei, mainly in the cerebrocerebellum, is the dentate nucleus. So dentate nucleus is the farthest, and close in the midline is the vestigial nuclei, and between these two is the interpositus nucleus or intermediate nucleus, which consists of globose nucleus and emboliform nucleus. So the vestigial nuclei and interpositus nuclei, they belong to spinocerebellum, and dentate nucleus belongs to cerebrocerebellum. And if you see here in the vestibulocerebellum, which consists of nodule, this nodule is connected to the spinocerebellum, so its nucleus will be vestigial nucleus. The lateral part of this vestibulocerebellum is almost free and is called as flocculus, so it is not related or in association with other nuclei other than the vestigial nuclei. Now let us understand what tracts go to spinocerebellum. Before I come to this point, let me tell you that there are conscious ascending tracts which are in the dorsal column. These tracts are also called as dorsal medial lemniscal tract, and these tracts carry sensation of touch and vibration. These tracts, they ascend upwards and end up in the thalamus. Then from the thalamus, this tract goes to post-central gyrus, where the sensation of touch or vibration is perceived. There are also unconscious ascending tracts, and these unconscious ascending tracts are anterior spinocerebellar tract and posterior spinocerebellar tract. As the name suggests, that these tracts, they go to spinocerebellum. You can see here anterior spinocerebellar tract, and posterior to this is posterior spinocerebellar tract, and these two tracts lie at the periphery of lateral funiculus. This is lateral funiculus, which is lateral to lateral horn. It is here, lateral funiculus, lateral to lateral horn, and it is at the periphery of this lateral funiculus, or you can say lateral segment of the spinal cord, that you see anterior spinocerebellar tract and posterior spinocerebellar tract. The posterior spinocerebellar tract and anterior spinocerebellar tract, they come from the lower part of the trunk and lower limbs, and posterior spinocerebellar tract, it carries the proprioceptive sensation, and it monitors the length and tension in the muscles, as well as carries the joint sense. The anterior spinocerebellar tract carries the crude touch and pressure, and some books say that this tract also carries some proprioceptive sensation, but mainly the anterior spinocerebellar tract carries the crude touch, sensation of crude touch and pressure, and this anterior and posterior spinocerebellar tract ascends upwards and go to the spinocerebellum, and we know that in spinocerebellum is the vestigial nucleus and interpositus nucleus. So this tract makes connection with spinocerebellum. So the anterior and posterior spinocerebellar tracts, they enter into the spinocerebellum, which is made of vermis and paravermis. It is here in spinocerebellum that spinocerebellar tracts are connected. As we have noticed that it is anterior spinocerebellar tract and posterior spinocerebellar tract from the lower trunk and lower limbs. It is this tract that goes to spinocerebellum from the lower limbs. The posterior spinocerebellar tract actually arises from muscle spindles and Golgi tendon organs, which are situated in the muscle and at the tendons, and these structures, the muscle spindles and Golgi tendon organs, they give information about the state of contraction of muscles, about their tension, pressure and length, as well as about the joint sense. And this information is carried by the posterior spinocerebellar tract that goes through the posterior root, then through the posterior root ganglion or dorsal root ganglion, and then enter into the spinal cord. Here we should understand that this tract does not cross to other side of the spinal cord. Instead, they ascend upwards along the same side to reach the upper part of the medulla, and from the upper part of the medulla they go to the spinocerebellum through inferior cerebellar peduncle. The other tract is anterior spinocerebellar tract, and this tract also comes from the lower part of the trunk and lower limbs, and also arises from the Golgi tendon organs and muscle spindles, but this tract mainly carries the sensation of crude touch and pressure. Some books write that it also carries the information about the proprioceptive sensations. But let me stress here that most of the books write that it carries the sensation of crude touch and pressure from the lower limbs. And this tract goes through the posterior root and through the posterior root ganglia or dorsal root ganglia, and from here they enter the spinal cord. But here we should understand that this tract crosses to other side of the spinal cord, and after crossing to other side of the spinal cord, it ascends upwards through the medulla and pons to reach the lower part of the midbrain, and from the lower part of the midbrain it again crosses to other side. It again crosses to reach the cerebellum of the same side, and therefore this tract is double crosser. It crosses first at the level of spinal cord, and then it crosses at the level of lower part of the midbrain. As I said that from the lower part of the midbrain, it goes through the superior cerebellar peduncle to reach the spinocerebellum of the same side. So this double crossing is actually needed to make the tract to reach the same side of spinocerebellum area. To repeat again, you can see here the posterior spinocerebellar tract arising from the Golgi tendon organs and muscle spindles go through the dorsal root and dorsal root ganglia to enter the spinal cord, and then it ascends upwards without crossing to other side of the spinal cord. It passes upwards and reaches the medulla, and in the medulla it enters the inferior cerebellar peduncle to reach the spinocerebellum of the same side of the body. So if I show again here, so one tract is posterior spinocerebellar tract, which carries the sensation, proprioceptive sensation, and it ascends upwards without crossing and enters the spinocerebellum through the inferior cerebellar peduncle, while as the anterior spinocerebellar tract has crossed to the other side of the spinal cord, then it ascends upwards, then again crosses, and then enters through the superior cerebellar peduncle into the spinocerebellum. This anterior spinocerebellar tract carries mainly the sensation of crude touch and pressure. So one tract does not cross at the level of spinal cord, the other tract crosses at the level of spinal cord as well as at the level of the midbrain. So that was about the proprioceptive sensation from the lower part of the trunk and lower limbs. Now what happens in the upper limbs? So upper limbs, we don't call them as anterior and posterior spinocerebellar tracts, but we call them as cuneo-cerebellar tract and rostral spinocerebellar tract. The cuneo-cerebellar tract from the upper part of the trunk and upper limbs arises from Golgi tendon organs and muscle spindles, carrying the sensation of tension, state of contraction, length of muscles and joint sense, and this cuneo-cerebellar tract goes into the dorsal root and dorsal root ganglia, then it enters the spinal cord, and without crossing it ascends upwards, and then through the inferior cerebellar peduncle it enters the spinocerebellum. If I summarize here, I said that from the lower part of the trunk and lower limbs arises anterior spinocerebellar tract and posterior spinocerebellar tract. The anterior spinocerebellar tract carries the proprioceptive sensation, and this tract, after crossing the spinal cord, ascends upwards and reaches the midbrain, and from the midbrain it crosses again to reach the spinocerebellum of the same side of body. And in the upper limbs we call it as rostral spinocerebellar tract, and this tract also enters the spinocerebellum through superior cerebellar peduncle, and both rostral spinocerebellar tract and anterior spinocerebellar tract carries mainly the sensation of crude touch and pressure, as well as some books write that it also carries the proprioceptive sensation. While as the another tract from the lower part of the trunk and lower limbs is the dorsal spinocerebellar tract, which does not cross to other side of spinal cord and ascends upwards to reach the inferior cerebellar peduncle in the medulla, and through inferior cerebellar peduncle it enters the spinocerebellum. And similar tract in the upper limb is called as cuneo-cerebellar tract, which also carries mainly the proprioceptive sensations from the upper limb, and along with the posterior spinocerebellar tract it enters through the inferior cerebellar peduncle into the spinocerebellum. So you can see here, then through the inferior cerebellar peduncle also enters this tract. This is dorsal spinocerebellar tract and cuneo-cerebellar tract that carry proprioceptive sensation from the lower limbs and upper limbs. And if you see the fibers that enter through the superior cerebellar peduncle into the spinocerebellum or anterior spinocerebellar tract, so this tract, and rostral spinocerebellar tract is this tract. The anterior spinocerebellar tract is from the lower limb and rostral spinocerebellar tract is from the upper limb, and both these tracts enter through the superior cerebellar peduncle into the spinocerebellum, and these tracts mainly carry the sensation of crude touch and pressure from the lower limbs and upper limbs. Some books write that they also carry proprioceptive sensations. So all these tracts which go to the spinocerebellum actually are connected to the vestigial nucleus, because we know that spinocerebellum contains the vestigial nucleus which is in the vermis, and also have connections with the interpositus nucleus, but mainly the connection is with the vestigial nucleus of spinocerebellum. Now if I summarize here, I said that dorsal spinocerebellar tract that comes from the lower part of the trunk and lower limbs carry proprioception, that is, it carries the information about the tension length, pressure, stretch of muscles, as well as the position of joints. So this information is carried by this tract that ascends upwards in the spinal cord without crossing to other side, and it moves up and reaches the medulla, upper part of the medulla, from where it passes through the inferior cerebellar peduncle and enters the spinocerebellum. While as in the upper part of the trunk and upper limbs, it is the cuneo-cerebellar tract that carries proprioceptive sensation, and this tract also ascends upwards along with the dorsal spinocerebellar tract, does not cross to other side, and along with the dorsal spinocerebellar tract it also enters the inferior cerebellar peduncle and then goes to spinocerebellum. So we have noted here that it is the dorsal spinocerebellar tract and cuneo-cerebellar tract that carry proprioception from the lower limbs and from the upper limbs and go through inferior cerebellar peduncle to spinocerebellum. The other tracts that come out or go to spinocerebellum are vestibulocerebellar tract. So it goes from the vestibular nuclei to the vestibulocerebellum, but this tract goes through the inferior cerebellar peduncle, and in return the tract comes from the vestibulocerebellum to the vestibular nuclei, and this tract will be called as cerebellovestibular tract, and this comes out through the inferior cerebellar peduncle. So there is to and fro tract between the vestibulocerebellum and vestibular nuclei through the inferior cerebellar peduncle. The one more tract that goes to the spinocerebellum is the tract that arises from the inferior olivary nucleus of medulla, and this tract goes to other side of the cerebellum and ends up in the spinocerebellum by entering through inferior cerebellar peduncle. And inferior olivary nucleus in return gets a tract from spinocerebellum which will be called as cerebello-olivary tract. So this is also to and fro tract between the spinocerebellum and inferior olivary nucleus. So these are the tracts which pass through the inferior cerebellar peduncle. Now that was about the dorsal spinocerebellar tract and cuneo-cerebellar tract. Now we come to anterior spinocerebellar tract and rostral spinocerebellar tract. As we have known that anterior spinocerebellar tract enters the spinal cord and crosses to other side, then ascends upwards to reach the midbrain, and from the midbrain it crosses again to reach to the same side of the cerebellum. So the anterior spinocerebellar tract crosses twice, which is already known to us, and this anterior spinocerebellar tract carries the sensation of crude touch and pressure, and this tract goes to the spinocerebellum of the same side through superior cerebellar peduncle. The rostral spinocerebellar tract is the tract of upper part of the trunk and upper limbs, and this is like anterior spinocerebellar tract, and this rostral spinocerebellar tract carries the sensation of crude touch and pressure, but from the upper part of the trunk and upper limbs, and it goes along with the anterior spinocerebellar tract through the superior cerebellar peduncle to the spinocerebellum, and this tract also carries the sensation of crude touch and pressure. Some books write that anterior spinocerebellar tract is also concerned with proprioception, but majority of the books write that they particularly and mainly carry the sensation of crude touch and pressure from the lower limbs and upper limbs respectively. To show it again here, you can see here the ventral spinocerebellar tract or anterior spinocerebellar tract and rostral spinocerebellar tract, they ascend upwards, and through the superior cerebellar peduncle it enters the spinocerebellum, and we know in spinocerebellum there is vestigial nucleus and interpositus nucleus. The other tracts which come out of superior cerebellar peduncle is dentothalamic and dentorubral tracts. These tracts, they come out of dentate nucleus through superior cerebellar peduncle, and we know that dentate nucleus is in cerebrocerebellum, and cerebrocerebellum makes connection with the cerebral cortex via the thalamus. So the tract will be called as dentothalamo-cerebral tract, which is an outgoing tract to reach the cerebral cortex. And the other tract which comes out from the dentate nucleus, that is from cerebrocerebellum, is dentorubral tract, and then from the red nucleus the tract will go to the spinal cord, so it will be called as rubrospinal tract. But we have to understand here that the tract which comes out from the cerebellum, that is dentothalamic tract, it actually goes to other side of the cerebral cortex. So it crosses to other side to reach the cerebral cortex. And there is also a tract which comes then from the cerebral cortex to the cerebrocerebellum, but that tract mainly enters to cerebrocerebellum through middle cerebellar peduncle. So the main tract in middle cerebellar peduncle is cerebropontocerebellar tract. So from the cerebral cortex to pons or the pontine nuclei, and from pontine nuclei to the other side of cerebrocerebellum, and the tract will be called as cerebropontocerebellar tract. So there is a outgoing tract to cerebral cortex and incoming tract from cerebral cortex to cerebrocerebellum. So that was about the inferior cerebellar peduncle and superior cerebellar peduncle. Now if I come to middle cerebellar peduncle, then you can see here this is the middle cerebellar peduncle. The only major tract that goes through middle cerebellar peduncle to cerebrocerebellum, that is in cerebrocerebellum there will be dentate nucleus, as I said. So the tract is coming from cerebral cortex and it comes down to the pontine nuclei. So from pontine nuclei it goes to other side of the cerebrocerebellum through middle cerebellar peduncle. So this tract will be called as cerebropontine cerebellar tract, and by this connection the cerebrocerebellum coordinates and cooperates with the cerebral cortex. So there is a outgoing tract from cerebrocerebellum to the cortex, and there is an incoming tract from cerebral cortex to cerebrocerebellum. Now what have we learned about spinocerebellum? Spinocerebellum, as we know, receives proprioceptive sensation from lower part of trunk and lower limbs by ventral and dorsal spinocerebellar tracts. It also receives proprioceptive sensation from upper part of trunk and upper limbs by cuneo-cerebellar and rostral spinocerebellar tract. By these tracts, spinocerebellum remains aware about the position, tension and stretch and length of muscles. It also remains aware about the state of tone and state of contraction or relaxation of muscles. These tracts also keep spinocerebellum aware about the position of joints in relation to space and surroundings and in relation to one's body. All this proprioceptive information is also passed on to cerebral cortex, and both cerebrum and cerebellum as well as brainstem need this information to execute smooth coordinated movements. Damage to spinocerebellum causes errors in force and direction of movements, as well as causes errors in speed and amplitude of movements, resulting in misdirected or disordered movements of head, neck, trunk and limbs. Coordination and smoothness in movements is lost. Speech and eye movements become jerky and disordered. Due to unawareness of position of muscles and joints, patient won't even know which muscles to contract and which muscles to relax in response to different movements. Tone and tautness of muscles as well as posture get disturbed, resulting in misdirected, undershoot or overshoot movements. Patient has now problem in judging distances and ranges of movement, which commonly result in dysmetria. Movements which were supposed to be smooth, coordinated and well planned are now disordered. jerky and halting. Because during act of moving of limbs, cerebellum does not remain aware where the position of hands or arm is, nor does it remain aware where position of foot or leg is, so the movements won't be accurate and precise. The one side or whole body may become shaky, tremulous when person is moving his body or limbs. He may not be able to walk properly and may sway from one side to other with tendency to fall. Talking also is shaky and jerky, called scanning speech. Scanning speech, also known as explosive speech or staccato speech, is a type of speech in which spoken words are broken up into separate syllabi, often separated by noticeable pause and spoken with varying force. The sentence walking is good exercise, for example, might be pronounced as walk, then pause, ing, then pause, x, then pause, er, then pause. So there will be pauses in between the words. Additionally, stress may be placed on unusual syllabi. If you ask the patient to perform rapid alternating movements, he won't, because it won't be smooth, but instead defective, jerky and slow, not precise in range and timing. When he tries to reach target, if asked to stretch his hands to get object, then his hands and arm become full of tremors or jerks, overshoots or undershoots the target. Damage to vermis or midline portion of spinocerebellum leads to truncal ataxia, since the trunk is very close and near to vermis. The patient won't be able to sit up of its own when lying on bed, or if he tries to do so, it will not be smooth at all and will sway side to side as far as his trunk is concerned. If damage in spinocerebellum is localized more laterally than that is, if paravermis is involved, then there is more likely to be disrupt of fine movements of hands or limbs, which are called as ballistic movements. For example, while playing piano or trying to hold objects or unbutton his dress, then such movements won't be smooth. They may be jerky and clumsy, losing distance, timing and range of movements, as well as poorly coordinated. Thus, if person tries to walk, he won't walk smoothly, but will sway from side to side with difficulty to balance himself, causing unsteady gait or ataxia. This is because spinocerebellum has problem in receiving the information about joint and position sense of limbs and of different parts of body, which it could have used to modify descending motor commands from cerebrum so as to facilitate smooth movement. The information and awareness of position of muscles and joints actually reach vestigial nucleus, which is located in vermis, and also reaches to interpositus nucleus consisting of globose nucleus and emboliform nucleus that lie in the paravermis. I must tell here that vestibulocerebellum connects with vestibular nuclei and tectum of midbrain that give out then vestibulospinal tract and tectospinal tract. These tracts keep head and neck and eye movements in balance, in response to surroundings and in response to space and in response to visual and auditory stimuli. The vestigial nucleus then gives fiber also gives fibers to reticular nuclei of midbrain, pons and medulla, which is called as cerebello-reticular tracts, which then give reticulospinal tract from these reticular nuclei that go down in spinal cord. The reticulospinal tract affect muscle tone that in turn affect movements of muscles and joints of body. Similarly, interpositus nucleus of paravermis of spinocerebellum sends fibers to contralateral red nucleus, which is called as vestibulocerebellar tract, that in turn sends down rubrospinal tract that mainly influences flexor muscles of body and limbs. Besides all these tracts, spinocerebellum also receives acoustic and visual fibers via superior and inferior colliculus connections. These tracts coordinate eye movements in response to sound and sight. The dentate nucleus that lies in the cerebrocerebellum gives fibers to thalamus of opposite side, which is called as cerebellothalamic tract, and then from thalamus to cerebral cortex, which is called as cerebellothalamo-cortical tract. This tract keeps cerebrum aware about happenings in cerebellum and giving information to cerebrum as how to adjust and modify movements according to the need. The most important and only major tract that goes to cerebellum from cerebral cortex is called cerebropontocerebellar tract, that sends modifying commands to cerebellum about movements of body. These commands are reinforced by cerebellum through extrapyramidal tracts to bring in desired tone and posture in muscles and in smooth conduction of movements. Thus we have known that extrapyramidal tracts are following: vestibulospinal tract, tectospinal tract, rubrospinal tract, reticulospinal tract, corticobulbar tract, olivospinal tract, which is from inferior olivary nucleus of medulla. The spinocerebellum makes to and fro connection with inferior olivary nucleus, then to spinal cord as olivospinal tract. One must note here that the major ingoing tracts to cerebellum are through inferior cerebellar peduncle, and major outgoing tracts from cerebellum are through superior cerebellar peduncle. In normal conditions, these extrapyramidal tracts of brainstem play a major role in contributing both excitatory and inhibitory effect on the muscles, thereby regulating tone and posture. All these major tracts cause muscle tone and posture to change now and then during act of movements of body. These tracts work alongside and in association with corticospinal pathway through anterior horns. Most of these tracts are facilitatory to tone.